resected kidney that is hugely enlarged with multiple cysts. Look, multiple cysts cannot elongate in the downward direction, rather they move in the sideways, laterally to evaginate. And with further proliferation and continuous rapid proliferation, at a stage of time, this evagination gets separated from its parent tubule. So these are the other pathology associated with polycystic kidney. Maybe liver cyst, maybe pancreatic cyst, maybe berienism in brain, maybe mitral valve prolapse. Okay. Discuss this topic, polycystic kidney disease, along with a new station, that is renal cell carcinoma. I will discuss few questions about renal cell carcinoma. First, polycystic kidney disease. Look, a picture is shown here. We all can understand this is a resected specimen of kidney. The first question will be, have you gone through the picture? Have you understood? The examiner will ask you, have you understood? Now tell me the gross pathology. What can you see in this picture? So it is enlarged specimen of resected kidney that is hugely enlarged with multiple cysts. Look, multiple cysts with area of necrosis and hemorrhage. We can obviously see here are the area of hemorrhage and these are black cysts. The blackening denotes area of necrosis. So this is a polycystic kidney complicated by areas of hemorrhage and necrosis. Okay. So the scenario is patient with adult autosomal dominant polycystic kidney. ADPKD means autosomal dominant polycystic kidney and APKD means adult polycystic kidney. Adult polycystic kidney disease is autosomal dominant, and in childhood those are rare, but those are autosomal recessive. You all know by this time recessive disorders manifest early and the dominant disorder manifests in the later stage of life. So it is ADPKD going for bilateral nephrectomy due to intractable abdominal pain. So firstly, the question is, why is there pain in polycystic kidney disease? Two questions I have, two answers I have already mentioned. One is necrosis, hemorrhage. Another will be due to this large size. It drags its pedicle down and stretching of the capsule cause neural pain, okay, compression and stretching of the capsule. And finally, there may be infection, okay. So, discussed it, mode of inheritance, it is autosomal dominant due to, have to remember these two genes, one is PKD1 and PKD2, okay. So pathogenesis of the cyst formation, okay. So pathogenesis of the cyst formation, look, what happens actually, we know the nephrons are the basic structural unit of kidney, right? Nephrons are basic structural unit of kidney where they are composed of either glomerulus and some renal tubules, proximal tubule, distal tubule, and all the tubular epithelial cell goes wear and tear in a regular period, basis of period. So during wear and tear, it is genetically controlled. The rate is genetically controlled, that how fast it should occur. But when those genes are mutated that control the rate of this wear and tear, when those genes are mutated, the rate becomes faster. The genes are PKD1 and PKD2. When mutation occurs in those two genes, polycystin, this polycystin protein, the role of this polycystin protein is increased synthesis of those cells or cellular components. So the tubular cells, tubular epithelial cells grow faster and proliferate faster. When, suppose this is the proximal convoluted tubule, when the tubular cells proliferate faster, they cannot elongate more. Okay, they cannot elongate more in longitudinal direction. Rather, they try to form this evaginations or this type of diverticulation. due to rapid proliferation, let me make it clear again. Due to rapid proliferation, these tubular cells cannot elongate in the downward direction, rather they move in the sideways, laterally to evaginate. And with further proliferation and continuous rapid proliferation, at a stage of time, this evagination gets separated from its parent tubule and make a cyst. And with continuous secretion by those epithelial cells, the cyst become larger, and when a cyst becomes larger, the center undergoes ischemia, and due to gradual enlargement, some cysts undergo necrosis and bleeding occurs, and the kidney gets enlarged in a huge size. So this is basically the pathology. Look, the renal tubules divide repeatedly until causing an outpocketing. Until an outpocketing of the tubular cell wall with the formation of a saccular cyst that fills with fluid derived from the GFR, glomerular filtrate, GF. And with progressive expansion eventually causes most of the emerging cyst to separate from the parent tubule, leaving an isolated sac that fills with the fluid with transepithelial secretion. Mind it, the mode of secretion is transepithelial secretion in between the epithelium. And this isolated cyst expands relentlessly as a result of continuous proliferation and with the transepithelial secretion of sodium chloride and water into the lumen. So this is the basic pathology of polycystic kidney disease. And just you have to mention in your own words, there's no bindings about the language, just to mention that it is the mutation of the PKD1 and PKD2 which resulting in increased formation of polycystin protein, and that causes continuous proliferation of the epithelial cells and cyst formation. The cyst enlarges gradually, and the kidney becomes enlarged, and ultimately the larger cyst undergo ischemia and necrosis and hemorrhage occurs. Okay, so what are the other organs in abdomen causing cyst formation? Yes, liver, ovaries, pancreas, even lungs, intestine, spleen, they all can undergo cystic change. Okay, and sometimes it is seen simultaneously some solid organs undergo cystic formation. It's polycystic kidney disease can be related or can be accompanied by liver cyst, pancreatic cyst, spleen cyst. That is called von Hippel-Lindau disease. We'll come to that. Or syndrome, VHL syndrome. Okay, von Hippel-Lindau syndrome that causes cyst in kidney, cyst in liver, cyst in pancreas, cyst in spleen, along with hemangioblastoma of the cerebellum or central nervous system. So this is called von Hippel-Lindau syndrome.